I'm going to talk on non-invasive tests, or recently coined as non-invasive liver disease assessment as a predictor of liver and extrahepatic events. We know liver biopsy is the gold standard for assessment of fibrosis. There has been a lot of interest in development of non-invasive tests as biopsy has its own limitations. It is associated with complications and you cannot repeat it as required multiple times. The NITs have been developed. They are either serology based, imaging based, or a combination of these. The serology based NITs include FIB4, NFS, APRI, ELF, AST to ALT ratio, fibrotest, fibrometer, and post-C3. Imaging based NITs includes VCTE, or FibroScan, shear wave elastography, MRE, or a combination of scores which have come up recently that includes MAST, MEFIB, FAST, and AGILE scores. Most of these NITs, which have been used for predicting fibrosis, the data stems from etiologies, predominantly hepatitis B virus, hepatitis C virus, and non-alcoholic fatty liver disease, or recently recoined as MASLD. So our case for discussion for today is a 45-year-old MASLD patient who's got diabetes, FIB scores 2.8, LSM 14, FAST 0.7. Let's look at how do these use of NITs as single point assessments or repeated values over time help in predicting fibrosis, liver-related events which I'll be taking into account as published in studies that includes decompensation, development of HCC or mortality, extrahepatic events in form of cardiovascular events and cancers. This study from Professor Sanyal groups showed us that liver histology helps categorizing patients into different classes based on their histological grade of fibrosis, so we can categorize these patients in form of death, hepatic decompensation, and development of hepatocellular carcinoma. What this study also importantly showed us that the incidence of cardiovascular events and non-hepatic cancers was similar across the various fibrosis stage. To reiterate, non-invasive tests which have been developed assess fibrosis in the liver. How do NITs perform for advanced fibrosis in MASLD in South Asian population? This study was alluded to you by Manas. We included multiple centers across Asia, from India, Singapore, and China. There have been various cutoffs for various non-invasive tests which have been reported in literature. The data stems predominantly from the Caucasian population, and there have been various cutoffs given to rule in and rule out advanced fibrosis. What we showed in this study is the cutoffs which have been proposed from the Western population do not fare that well in patients with South Asians. And different cutoffs can be used to look at the 90% sensitivity and specificity cutoffs from the South Asian population, highlighting that cutoffs vary with different populations. The area under curve for performance of various NITs was highest for the VCTE based, that includes the FibroScan, and the scores which have been developed that includes the AGILE-III. Whereas the rest of the blood-based NITs had a performance which was suboptimal with an area underscore less than 0.7. There is also a discordance between when we use different NITs. This study from the US showed that when we use FIB4 as the first screening tool and patients are categorized as low risk, and when LSM is used as the second step, we find that almost 10% of the patients are misclassified. This percentage of patients who are misclassified increases significantly higher in those individuals who have been classified as high risk based on FIB4, and this misclassification goes to as high as 80%, highlighting the fact again, which we've been discussing since the first session, is the scores do change and then we need better cutoffs for these scores. So NIT, as I said, assess the fibrosis, and this individual patient meta-analysis of 25 studies, including 2,500 patients, showed that, again, what has been shown by Professor Sanyal's study is that histology and the NITs can categorize patients into different outcomes in terms of survival. Whether it is LSM, FIB4 and NFS, we can categorize into different outcomes. And the area under curve for performance of these NITs also remains similar, that is more than above 0.7 at 3, 5 and 10 years. What this IPMA also showed that when the NITs were compared to histology, whether it was LSM, FIB4 or NFS, there was no statistical significant difference in the performance of NITs compared to histology for all cause of mortality and liver-related events. But what this IPMA also showed us clearly is that the NITs don't perform well for non-primary liver cancer. So when we look at extrahepatic events, NITs don't perform that well, and even for cardiovascular events, the NITs don't perform well as they perform well for the LREs. Our own data suggests that you can categorize patients with different outcomes based on the LSM values done at baseline. This large study from the Europe included more than 1,000 patients with a follow-up of 5 years, again showed similar results, showing that the NITs help categorize patients with liver-related events, development of HCC and mortality, and do not perform that well for cardiovascular events and extrahepatic cancers. This recent study says that from the UK Biobank included almost like 4 lakh people, showed that NITs possibly could have some role in predicting incident heart failure in the general population cohort. NIT-based scores have been proposed for the prediction of HCCs, and this study on the hepatitis B virus patients showed that inclusion of NITs, including liver stiffness measurement, combined with demographics and lab parameters, can help predict patients who are going to develop HCC in patients with hepatitis B virus infection. LSM has also been shown for prediction of HCC in this cohort of patients of hepatitis C virus cirrhosis patients in a veterans cohort from US, which showed that the risk of HCC increases with the increasing liver stiffness measurements, and similar results were also seen when patients were categorized based on their FIB4 scores, suggesting that this could be used for predicting the development of HCCs in the HCV treated patients. NITs, including what this study showed, was that high FAST score, AGILE-3 and AGILE-4 scores are associated with an impairment of health-related quality of life in patients with MASLD. ELF, which is a proprietary score, which is recently now available in India, being marketed by Siemens. And what this study showed, which included almost like 1,300 patients from Europe, an increasing ELF score was associated with a poorer survival, and patients could be categorized based on their ELF score, thus predicting their outcomes on the basis of the ELF score. So far what we have seen is the single time prediction of baseline non-invasive tests in predicting outcome. How about a combination of these tests? So what this study showed is a combination of FIB4 and VCT algorithm for predicting liver-related events. And what this study showed is that individuals having a FIB4 more than 1.3 and a VCTE more than 12 are at the highest risk for developing liver-related events. How about change in scores? So dynamic scores are always better, and what this study showed is that a 1 unit increase in FIB score was associated with a risk of severe liver disease, which was defined as cirrhosis, liver failure, HCC, and liver transplantation, and the risk increased linearly with the increasing FIB score since the time of baseline evaluation. About change in liver stiffness, a 20% increase in liver stiffness has been shown to be associated with increased risk of liver-related events, including death, development of hepatocellular carcinoma. This study from the NASH CRN cohort included 1,400 patients with a follow-up of 4.4 years, and showed that patients who had an increase in liver stiffness value going above the cutoff of 10, which is defined as had a 400% increase in the risk of liver-related events. In contrast, a 75% reduction among those individuals who had a liver stiffness dropping below the cACLD cutoff of 10. MRE, which performs better than liver stiffness, has been shown to predict outcomes in terms of cirrhosis and decompensation in death, and with each increase in the baseline liver stiffness values assessed on MR, there is a difference in the risk of decompensation. Another study also highlighted that the MRE liver stiffness can predict complications and mortality, and this study included all etiologies. But what this also showed us that the prediction of cardiovascular events and extrahepatic cancers was not that well differentiated with the use of baseline liver stiffness measurements. Various different combinations of MRE with FIB-4 mass scores have been shown, again categorizing patients into different outcomes. There has been recent interest in omics, which helps in understanding the pathophysiology, development of new drug targets, and understanding and categorizing patients based on their phenotypes, which includes genomics, epigenomics, transcriptomics, proteomics, and metabolomics, lipidomics, and we've seen some data on these aspects in the previous talks. What this study showed is that PNPLA3 variants can help differentiate and categorize patients with MASLD into various risks of decompensation, HCC, and liver-related events. But what this also showed is that there was no association with cardiovascular events, extrahepatic cancers, and overall mortality in these patients. This study showed that a composite model consisting of 4 proteins and demographic features in terms of body mass index and type 2 diabetes can identify patients at risk of developing at risk of steatohepatitis. And this study showed that proteomics can differentiate patients with NFL and cirrhosis and those who have cirrhosis with the general population. But we need more data on proteomics in terms of their prediction for liver-related events and non-liver-related events. So, ladies and gentlemen, to conclude, the available data on non-invasive tests suggests that these tests perform better for liver-related events, but they do not perform that well for extrahepatic events. The NITs have been developed for predicting fibrosis. Their cutoffs vary across population. These need to be validated across populations. We have limited amount of data for these cutoffs for predicting outcomes, and that too is available from few centers. These cutoffs need to be validated across globe, across multiple centers, and the existing data which is available at present is predominantly from baseline variables. We know that now drugs are available and parameters do change dynamically. It's possible that these NITs, when used in combination or when used in dynamic scores, may perform better for predicting outcomes, and we need more data in terms of how do these NITs perform for extrahepatic events in patients with liver disease.
Thank you, Dr. Shalimar.
Thank you.